Hello and welcome to this Q&A from the Fertility Alliance. Today we're going to be talking about PCOS, polycystic ovary syndrome, and we're joined by Professor Adam Balen, who's a member of our advisory board and also a world expert, in fact, on PCOS. So just the person to be speaking to about this subject. So Professor Balen, welcome to the Q&A. The first question I wanted to ask you was, what actually is PCOS?
Thank you, Kate, and it's a pleasure to be here. So polycystic ovary syndrome is a common condition, probably occurs in at least 10% of women. Essentially, it's a spectrum of problems that affects different people in different ways. So you have polycystic ovaries, which are essentially ovaries that have more than the usual number of the little egg-containing follicles or cysts. These are tiny, but a polycystic ovary usually has at least 20 follicles per ovary. A young woman with normal ovaries would probably have more in the region of 10. So you have at least double the number of follicles. That leads to an imbalance in hormone production, both by the ovaries, and there are other hormonal disturbances that can occur as well, that then lead to the various symptoms. The commonest symptoms being an irregular menstrual cycle, so infrequent menstrual bleeds, or sometimes a complete absence of the menstrual cycle. And of course, in the context of fertility, that means either lack of ovulation or infrequent ovulation. And one of the other main symptoms is androgen excess. So the androgen hormones come from the ovaries. Testosterone is the best known. All women make testosterone from the ovaries. Testosterone actually gets converted into estrogen. But excess testosterone that you see in women with polycystic ovary syndrome leads to unwanted hair growth, often predominantly on the face, the chin, other parts of the body, sometimes thinning of the hair on the head, sometimes acne spots as well. So those can be quite distressing symptoms. And one of the other main issues that women with PCOS experience is an easy ability to gain weight and a difficulty to lose weight, and that's for a variety of reasons that we may come on to. But basically, those women with PCOS who are overweight, and not all women with PCOS are overweight, but if overweight, they tend to have worsening symptoms. It's harder to manage, both in the context of the skin problems and everything else, but in particular, the fertility problems are harder to manage. And there are worsening problems in pregnancy, increased risk of miscarriage, and all sorts of other things that we may come on to as well. So being overweight certainly causes a lot of distress, as do the other symptoms of PCOS, but it can be difficult to manage and difficult to actually manage PCOS as a whole in those women who have gained weight.
And does it always cause problems for people trying to get pregnant, or do some people with PCOS get pregnant without any difficulty?
Some women do get pregnant without difficulty because some women with PCOS do have fairly regular periods, and if their weight is normal, then they'll be ovulating and can conceive naturally. So many do. And actually, it's been shown, interestingly, that women with PCOS usually have their desired family size, but it takes them longer to achieve a family. So don't lose hope, but do seek advice.
That's a very heartening fact that actually most people do go on to get pregnant. So what sort of treatments would you give to someone with PCOS if they came to see you? What's the first thing that you'd suggest?
Well, we run through things obviously with both the woman with PCOS and her partner, make sure that they're fully investigated and that their health is optimized, that they're taking the appropriate supplements, in particular folate, higher dose of folate for those who are overweight, vitamin D and other supplements. So again, we may talk in more detail about supplements on another occasion, but it's a sort of that's the basic assessment, basic advice. And then advice about weight management, which can be, easier said than done. There are some drugs that can help kickstart weight management, but again, there are cautions when it comes to trying to conceive. And basically, there's no substitute from, healthy eating and regular exercise and the support of a well-qualified expert in reproductive nutrition is obviously going to be beneficial as well. And then we move on to fertility treatments after usually checking for a woman in a relationship with a man that he has a normal semen analysis. For a woman who needs ovulation induction, we talk about checking the fallopian tubes before starting any treatment, and then we move on to medication to try to stimulate regular ovulation. There are a number of drugs. Many people will have heard of Clomid or clomiphene citrate, which for many years historically was the sort of first-line treatment. That has now been replaced, particularly in the UK, with letrozole. So both clomiphene and letrozole are tablets taken for 5 days at the start of the menstrual cycle, so usually start on day 1 or day 2. If a woman isn't having regular bleeds, then we give a course of a progesterone hormone to bring on an artificial bleed before then commencing letrozole. We advise that letrozole treatment should be monitored with ultrasound for a number of reasons, predominantly to ensure that the ovaries are responding, but also to make sure they're not over-responding, because the main risk of any drugs to stimulate ovulation is multiple ovulation and multiple pregnancy. So we're always aiming ideally for a singleton pregnancy. We accept the small risk of twins. We like the twin rate to be less than 5%. Even twins bring with them more complications in a pregnancy. So ideally, we're looking for a singleton. So we start off the treatment with a low dose of letrozole. We monitor with ultrasound. So what does that mean in practice? It means coming to a clinic for an ultrasound scan, usually after about a week, and then every 2 or 3 days until we see that ovulation has occurred or is about to occur, and we advise sexual intercourse around that time. Now, once we're happy that ovulation is occurring, there's an argument for relaxing the monitoring and not doing ultrasound monitoring every cycle. We have to accept that a pregnancy won't necessarily occur the first time. This depends upon the age of the woman, but on average, the chance of conceiving with one cycle is about 20% or so. So you may need repeated cycles. And again, this is a discussion that we would have with the individual depending upon what they want and their age and other factors. But in general, it would be 6 cycles of ovulation induction before moving on to the next line of fertility treatment.
And what is it?
Six cycles of letrozole if you're ovulating. But if you don't ovulate in response to letrozole, the next line treatment is hormone injections, so what's known as gonadotrophin injections. So gonadotrophins contain the hormones, follicle stimulating hormone, which stimulates the growth of the follicles, and sometimes contain LH, luteinizing hormone, as well. So those hormone injections are only given if you don't ovulate. It's not if you don't get pregnant, it's if you don't ovulate in response to letrozole, because it requires daily injections, it's more intense, and every cycle must be monitored with ultrasound because there's a much higher risk of multiple pregnancy. So gonadotrophin therapy again for 6 cycles, and if a pregnancy hasn't occurred, then we move on to IVF. There are also alternatives to gonadotrophin therapy. There's something called laparoscopic ovarian diathermy or drilling, which is a procedure that requires a general anesthetic and operation called a laparoscopy. It's an invasive procedure. It involves burning some small holes on the ovary, which sounds like a bit of an odd thing to be doing, but for reasons we don't fully understand, it does kickstart ovulation. Doesn't require the same intensity of monitoring, but it's not as effective as gonadotrophin therapy. So in our clinic, we don't do diathermy that much, but it can be helpful. As I said, third line therapy really is IVF. IVF may be required for women with PCOS if there are other problems. So if, for example, she has blocked fallopian tubes or a partner with a sperm problem, then they may need to go on to IVF. But IVF for women with PCOS does bring with it more risks compared with a woman who doesn't have polycystic ovaries because of a serious condition known as ovarian hyperstimulation syndrome, or OHSS. And so we have to use a specific protocol of medication when we're doing IVF for women with polycystic ovaries. These days, we usually freeze embryos and let the ovaries settle down to minimize the risk of OHSS developing. And also, it's been shown to be associated with an increased chance of a pregnancy if you use frozen embryos in the context of IVF. There are all sorts of other drugs that are talked about in the context of polycystic ovary syndrome. So a lot of people ask about metformin. It's something we've done a lot of research on. Metformin is a drug that helps with the management of high levels of insulin that you see in overweight women with PCOS. So it helps with the metabolic side of things. It can improve fertility a bit, but not as much as we once hoped. So we don't use metformin a huge amount. We tend to use it when we actually see that there is a metabolic problem. And if somebody either has diabetes or is in the early stages of diabetes, that's when drugs like metformin can be helpful. Some people obtain various forms of inositol, myo-inositol. There are various inositol preparations available online. They've become very popular. They don't do any harm, but they probably don't do a huge amount of benefit as well. Some women find that they're beneficial, can help kickstart weight reduction, can help with the metabolic problems, but the scientific evidence isn't that strong. And then there are all sorts of weight reducing medications. I use the word Ozempic because everybody talks about Ozempic, which is just the name of a drug in a certain group of drugs that is used for the management of diabetes, can help with weight reduction, but we advise against its use in somebody who's trying to get pregnant because of adverse effects in pregnancy. So whilst it can achieve significant weight reduction, you have to have a washout period of at least 6 to 8 weeks before trying to conceive after stopping it. And you can get a rebound in weight gain in that period of time. So there's no quick fix, as I was saying earlier, to weight loss. And whilst some of these drugs can be useful, they have to be used with caution in somebody trying to conceive.
So it sounds as if for someone with PCOS, there are quite a lot of options and each treatment seems to have another one. And you're saying that on the whole, people with PCOS do tend to end up with positive outcomes?
Yes, on the whole, it depends upon age and other factors. And of course, here in the UK, there are funding criteria which are also based upon a woman's weight, and there's quite a lot of debate about that. And actually, I'm leading a group for the British Fertility Society at the moment, updating the national guidelines on body weight and fertility, because that has been so sort of a controversial area. And as we know, our population as a whole is getting heavier, and being overweight impacts general health and in particular reproductive health.
If for whatever reason someone has a problem accessing funding for NHS IVF treatment locally, which could happen for a variety of reasons, perhaps even a previous child from a previous relationship for one of the partners, is it still, or should it still be possible for them to have all those other treatments leading up to that on the NHS anyway? So should it still be possible for them to have the drugs and things that you mentioned earlier?
It should be possible. GPs won't prescribe those drugs, and actually shouldn't really be prescribing because of the need of monitoring. So you do need to ask your GP to refer you through to a fertility clinic. and all good fertility clinics should be able to provide letrozole with appropriate monitoring. You may then need to go to a more specialist clinic that also does IVF to receive the gonadotrophin injections. So it depends upon where you are in the country. But yes, essentially, those treatments are available on the NHS, and the criteria aren't the same as for IVF.
Would you have any kind of basic advice about anything people can do themselves? I mean, obviously, we've talked a bit about losing weight if you are overweight. Are there other things that people can do for themselves to make things better with PCOS?
So you need to get yourself in a good state of mind, because having PCOS causes a huge amount of psychological distress, not only related to the fertility and irregular periods, but the skin and hair problems as well. So find yourself in a supportive environment. Many people link in with specialist nurses in fertility clinics, or nutritionists, or some people even go and have acupuncture or reflexology or mindfulness classes, those sorts of things. You have to be careful about the claims made by certain practitioners, because there's not hard evidence that they will actually improve your fertility, but they may improve your well-being. And the ability to do regular exercise makes people feel better. And trying to seize control of your symptoms, understanding what's going on by using the sort of resources available through the Fertility Alliance. Verity is the national PCOS support group that's got lots of useful information. Some of us have written books on fertility.
We'll include details of that on the website when we put this up as well,
um,
of your books. So,
um, which are designed to give you all of the information, hopefully with the knowledge to make changes. So it's not only about supplements, it's the diet that you eat. So the Mediterranean diet, for example, has been shown to be beneficial. So that's lots of fresh fruit and vegetables, using olive oil for cooking from scratch. It's simple principles, lean meat, fish, that sort of thing. Leads to sort of improved general health and improved reproductive health. Avoiding certain environmental pollutants, avoiding certain skin products that contain chemicals that can affect your reproductive health. Again, we've written a lot about that in our book, but there are lots of things that you can do that are all additive, that add into the mix. And I think feeling in control of your symptoms and understanding what's going on actually enables you to tackle it more constructively, and also manage things when it comes to interacting with healthcare professionals and asking the right questions, because we'll all want to answer questions. We're all happy to be challenged and have a discussion so that we can make a joint decision. I've mentioned that a few times, joint decision making about should you check somebody's fallopian tubes, how many cycles of letrozole before moving on to the next step. Some people don't want to have IVF, so we might do more ovulation induction. So it isn't I hate using the expression one size fits all, but we will have that discussion to enable people to go down a pathway that they feel comfortable with, at a pace that they feel comfortable with, and that's very important. So don't be afraid to ask, and hopefully have that discussion with the people looking after you.
Professor Adam Balen, thank you so much. So much really helpful and really useful advice there for anyone who wants to know more about PCOS. And you can find more of our Q&A videos on our YouTube channel, which you can access through our website. Thank you very much, Professor Adam Balen.